welcome to the Stronger After Stroke podcast. Today we are going to talk about issues about intimacy and sex after stroke. A lot of people struggle with issues around this area, and so I've pulled in a couple of key experts to speak to this. We have Lindsey Adler. She is a physical therapist who specializes in pelvic floor. And then we also have Michelle Stillwagon. She is a talk therapist who is a certified sex therapist.
Correct, yeah.
Are there any other credentials you would like to include in this list?
I'm a licensed marriage and family therapist and a certified sex therapist, yes.
Yes, okay. So to start off today, I want to ask questions of both of you, and we can just have a conversation about your experiences as providing support to these patients. How common is sexual dysfunction after stroke?
Well, it's very, very common. So it's something people don't talk about a lot because it is intimate, it's personal, and there's somewhat of a taboo surrounding it. But of the 795,000 adults who have a stroke, up to 60% report sexual dysfunction after. And even like 2 years later, 49% of people, partners and people that have experienced the stroke both report that they're dissatisfied with their sexual life.
Wow.
So it's incredibly common. And we kind of have, So a study that I have found online recently said that up to 71% of people with mild and moderate stroke are sent home pretty much immediately after they have the stroke without rehab. So sometimes we miss these people who are lacking in executive function control, which can contribute to difficulty in managing your personality or impulse control.
Executive function control, are you talking about people who are executives at companies?
No, maybe they were, doing that too. But executive functioning, really there are 8 kind of executive functions that are outlined in our personalities, and we have self-control, so your ability to stop and kind of like think about what you're doing, self-monitoring, so you can evaluate yourself, and that also includes something called interoception, which is do I need to eat, do I need to go to the bathroom? I feel like you hear a lot.
Like perceiving your own physical needs?
Perceiving yourself, yes, your ability to control your emotions, adapt to things, maintain flexibility. So sometimes people will come home and maybe it's not the physical thing that's preventing them from having intercourse, but maybe a partner will see a change in their spouse after the stroke just behaviorally. This person used to be very organized. This person used to plan our trips, and now
maybe they were the one who scheduled sex and now it's not happening.
Yes, now it's not happening.
Right. Because that is a thing some people need to do.
Exactly. Yeah, it's a time management with that.
Exactly.
So these things sometimes are just overlooked as maybe they're depressed or it's put into a different bucket when maybe it's really a cognitive processing disorder that hasn't been identified.
So as we look to identify cognitive processing disorders, let's see, what do you find, Michelle, is the most challenging to patients and partners in sex after stroke?
I think that it's certainly the physical piece is something that has to be creatively kind of considered in terms of, do you need support? Do you, can you lay comfortably? Can you feel your whole body, or do you need to see part of it in order to sort of be with yourself? And a lot of people, I think, when they leave the hospital are disembodied, don't feel like they're connected to their body. They're very much in their head. They've been worried. They've been looking to recovery, thinking about what they're going to need to do, maybe making appointments with you and other doctors. And so it's very cognitive. So then trying to get in this space where it can be more slowed down, more emotional, more connected. The physical can be a piece of it, but I think a lot of folks talk about the emotional piece and the self-esteem piece being a large part of what the struggle is too. So a lot of, kind of anxieties or concerns about how they feel about themselves, maybe how sex will be different with their partner. Can they do the same things, have the same positioning, enjoy it, feel it? So that's one of the things that I see and that I know is a struggle for folks with really kind of any chronic illness or disability at all.
Their body is changing. So what worked before may not work for them now. And does that mean they're not able to have that same enjoyment, or does it just need to look different?
No, they absolutely. Folks after any kind of episode, stroke episode, can have a very enjoyable sex life, but it takes a lot of honest communication with their partners, a lot of open-mindedness about, can we do this differently? Can we open up the definition even of what is sexual or sensual to us instead of just sexual? So it's not so goal-driven. It's not always about getting to an endpoint or an orgasm or needing to get to a certain place to feel successful. It could be that there's holding hands and there's more touch during the day, and there's something sprinkled through the week in terms of touch and affection and closeness instead of only sex. And then when in bed or wherever they may choose to be, to connect with one another, being able to be mindful and be aroused and take the pace at the rate it comes, but also not feel like they have to push or they have to get to a certain place to be successful. So really opening up the definition of what satisfactory means to me afterwards, to my partner, to us.
Which would be hard to be vulnerable when you're already feeling vulnerable from your physical state, and then to add more vulnerability emotionally would be hard. I mean, communication is harder than it should be for everyone.
Yeah, and we definitely want to talk about what consent might look like after stroke, because with stroke, if it affects the language center of your brain, you may have something known as aphasia, and it could be expressive, where you're unable to get out what you are thinking. You're having clear thoughts in your head, but the words are not coming out.
Exactly.
Or it could be not understanding the words being said to you, so you need to have demonstrations in other ways.
Absolutely, yes.
And then some people have global aphasia, where they can't understand things coming in or get anything else out.
Yes, that's what would be the most severe form of aphasia, right? Would be when both areas are affected. And that's something that, from my standpoint, I could think would be the most limiting, is just obtaining consent. How do I know? As a physical therapist, I don't do a ton with that, but I work very closely with the speech and occupational therapist. There are so many ways to learn communication, and just knowing your spouse from, pre-stroke to post-stroke. The partner provides so much insight on things like that, and they can see glimmers of this is who they are, this is who they are now, and we can kind of try to connect those two through communication devices or pictures or those
hand
speech
signals.
Yes, there's so many
ways that you can touch each other to say yes, or to say keep going more.
Exactly. Yes. So
that's great.
Yeah, and I think thinking about. A lot of times there's pressure on the partner as a caregiver, as a caretaker, as the roles switch pretty significantly. And so partners can maybe be even concerned about asking for what they want, or asking their partner to do something they're not sure whether they can resolve or not for themselves or be part of. And so it takes really slow and steady, working on it a little bit at a time, knowing that it's going to be a new normal. It's going to take some creative efforts and some trial and error. So there are going to be times that it's not working. And that's why having non-sexual, just kind of sensate focused touch, feeling your body, being in your body, feeling each other, being close to each other as like a way to build up to consent as well, so that you start to learn learn your partner's moans and groans, especially if there is aphasia, that you learn, their yeses and their nos in different ways.
Yeah, and it's just so hard to really clearly define just like the progress, because you're going to progress in your healing, for years after. And neuroplasticity is magical, and it's hard, like you just said, like the role definition, like, my partner is also my caregiver, is also my, is afraid to touch me, I'm afraid to be touched, and then just trying to like maintain communication and letting each other know, I'm ready to do this next step. Every person that comes in, I work a lot with chronic pain patients specifically, which includes post-stroke, if there are some tone changes or muscle tension changes.
Yes.
Nerve pain, exactly. And I always recommend that they see a counselor for that, because the communication is so hard. And even like with yourself internally, am I ready? And what are signs that I'm ready? So that's a testament to counseling, I feel like.
Yeah, and I think the readiness is definitely the willingness, like you were saying earlier, to be vulnerable, to try things and not know if it's going to work or not, and to take that chance. I think also, not feeling obligated because your partner's doing all these new things for you, and you feel like you need to be for them, everything they need, because they need to meet their needs, for themselves too, doing things they enjoy, going out of the house, doing things other than always being with a partner, and responsible for a partner, just to kind of expand on, the relationship beyond caregiver, caretaker, lover, partner, spouse, whatever the situation may be. And, I think for folks that are unpartnered too, there may still be sexual interest, there may still be sexual awareness in their body that they would like to explore. And that can be really trying, and that can be difficult too, especially depending on the level of control and things like that. So that will take some exploration as well, and some open-mindedness to, other tools and things and toys and such that can be used.
Yeah, and so I'd like to narrow down to some of the things that can help. Since that is your specialty as far as the pelvic floor, can you tell us, Lindsey, what is the pelvic floor and what does it have to do with sexual dysfunction?
Absolutely. So the pelvic floor is something that everybody has. It's a group
Even men?
Even men. Men, women, children. It's there when you're born. It has a couple different functions. It works with breathing muscles, your diaphragm. It helps control pressure in the abdomen. It helps, obviously there's openings to void your bowel and bladder, to urinate and to defecate, has a sexual role, and then it also helps with stabilizing your pelvis. If you have some low back pain and things like that, it might be coming from the inside out. Yeah, but in relationship to how we can help sexual gratification and improve our sex life with pelvic floor for men and women, whenever we do pelvic floor training, if we have increased tone or tight muscles down there, we can get a lot of pain disorders. So the pelvic floor can help with improving, like training specifically can help with improving lubrication, blood flow. When we have more blood, we have more estrogen to our estrogen receptor sites, the places in the vagina that receive that. And their role, the estrogen in the vagina makes the vagina more lubricated, makes the tissues better. It prevents against infection.
It's kind of like the
It's yes, it makes it feel less dry.
Right?
Yes, and a lot of people think, it logically so, that after a stroke we can't have hormone replacement therapy, which we
like
can't.
Oral contraceptives.
Yes, like through the mouth. Yeah, you don't want to take things that your body processes, but there are topical options or ointments that you put around the vagina, inside the vagina, that don't increase the risk. Now that's patient to patient, so definitely reach out to your team, your medical provider, and see your options. But they have come a long way with specialty compounded topicals to help with that. But pelvic floor training can help improve that as well without the risk.
And I will say this, just as a sex therapist, please, if you're having pain, stop. we want pleasure and we want consent. Those are my two must-haves in order to continue with whatever we're doing. If it's a great makeout session, if it's a longer kiss, whatever it may be, we want pleasure and consent. If you're having or trying to have any kind of intercourse and there's pain, especially in your pelvis region or as there's entry, if it's penis and vagina sex, then you want to stop because your mind will start to associate. Yes, sex is pain. Painful sex. Sex equals pain. Sex is bad.
Absolutely.
And we don't want that, particularly because, pleasure is such an important piece of not only coupling, but also just of life, the value of having something that makes you smile or feel good in your body.
Absolutely.
Is important.
And it's so much easier to treat if you catch it early.
Yeah.
And then when you get to the point where you're getting these, like, every stimulus is painful, sometimes it'll get to the point where, the drive is unaffected, and we don't want that. If we catch it early, it's way more manageable. So please don't be afraid to broach that topic. That's an excellent point.
Mm-hmm. Mm-hmm.
Yeah.
So then, how can pelvic floor therapy help? As in, is that like doing Kegels? What's involved in it?
So whenever you come in for a treatment session, at least through our services, you get a longer evaluation. And we do a big, long subjective history. We ask you all the questions. I always start off saying, I'm going to ask you a ton of personal questions. And if you don't want to answer them right now, you can waive it. But they all give a picture, a piece to the puzzle of what's happening, because we are not just the stroke that happened to us. Maybe we had weakness from having babies. Maybe we had a prostatectomy, for some prostate issues. And then the stroke was just the triggering factor that made the symptoms present. So we're not just one bucket, it's really hard to get out of that bucket once they put you in that diagnostic bucket. So we'll ask you a bunch of questions, and then we do a general physical screen. So we had to look if there's something from the hip, from the spine, from the ankle that's also affecting your dysfunction.
Oh, wow. That's far away from the pelvis.
I know. It's all the hip bone's connected to the knee bone. That's a real story.
That's a real story.
So anyway, so we do the assessment, and then there typically is some sort of an exam. If it doesn't need to be a rectal or a vaginal exam, we can either hold off and try other things first. And then I always tell my patients, if we get to that point and I say, hey, Mr. or Mrs. Smith, I'm a little stuck. I do believe an internal exam might help us, then we can broach it again. But there's never a set, you have to do this when you come in here. Our job is to make your life better.
It's not like when you schedule a pap smear and it's like that's what's happening.
A very appropriate analogy, yes. And so that's kind of how we start. And then we treat what we find, and we talk about medication management and other contributing factors, and we help coordinate care. We don't have prescriptive authority as PTs, but we have training in that. And so we can kind of just help be a part of the team and communicate with your team, because it's hard to
That's so
navigate.
important too. Coordination of care. For me especially, I'm so jealous that you get to be hands-on. You get to see. I ask a lot of questions too, probably some similar, less medical, more kind of about relationship, about closeness, about emotional, pieces to relationships. And because sometimes there's already marital strife going on previous to any kind of medical event. And so that can rear its ugly head a bit more, or become exacerbated by other stressors, in the marriage. And sometimes there's more like self-esteem issues or body image issues, or feeling like this is not what I'm used to. This is not my body. I used to be very active, and now I'm really having to sit out on a lot of activities that I used to find so much enjoyment from. And so, asking a lot of those things, but then being able to coordinate with you who can know and feel and see the internal piece as well is so important, because I'm frontline, for the emotional piece, but you're often frontline for the physical piece. And when it comes to pain management, or to finding a more creative solution to posturing, or to different positioning, or things that will create more sustained abilities for couples to have longer time together, longer sensual touch, longer sexual exposure to one another. Those are things that you can help me with. Absolutely. The doctors that are prescribing, because medications, as we all know, have an effect as well. and I know just enough to be dangerous.
Right.
So
Yes.
I need my
Yes.
doctors to tell, or your doctors really, to tell me, what the side effects may be,
Right.
or if you're experiencing those, if those are going to be something that we have to contend with as just part of the new normal and part of the reality.
Or can we switch it? Or is another option? And it's just communication.
Well, and sometimes the reality is such that it is what it is, but let's figure out how to look forward and how to be problem solving and how to be,
Manage it other ways.
Yeah, but looking for, solutions.
Right.
Not all. There's a grief, of course, within both partners
Right.
about what may have been what they're used to and what they've had together, and
The loss of the way it used to be.
yeah. And so getting into the new normal, getting into something different, there is a grief that goes with that. But then being able to look at things with a positive attitude and think, we're a team. We're gonna take this and we're gonna climb this mountain one step at a time, and we're gonna do it together, supporting one another, showing gratitude for one another, and for whatever we try. Thank you for holding space for me. Thank you for holding me.
Exactly.
That kind of thing.
And something I thought was really interesting in the book that you gave us, Rosa, was just there was an anecdotal part where a woman was telling a story about how after stroke she had a better sex life, and I thought that was like a good thing to highlight. Like she had more time, she had less
Intensity,
stress of like whatever she was doing, and I can't remember what she was
And
doing.
women do get so inhibited by all the stresses and
Oh,
the busyness
yes.
that we feel obligated to do and
Yes.
perform
Yes.
throughout the rest of life. Our performance anxiety is often about outside of the bedroom.
Oh,
and
yes,
that
totally.
impedes us in the bedroom.
Yes.
Well, it's hard to get out of your mind,
Yes.
and so especially, like anytime you're in your head a lot thinking about how you're having to do something and really thinking through the steps of it, it gets you up in your head. And so when you can try to get back into your body, oftentimes I'll have couples do relaxation exercises together, guided meditations. There's so many good.
Yes, and breathing, just to throw a pelvic floor, there's a whole course on breathing for just health of the pelvic floor.
Wow.
And how it works with like pressure regulation and blood flow and calming, like vagal nerve theory and all these things. So that's, anyway,
Because we want, we want everybody to be
hear
comfortable.
what experts you both are? You're just both sharing all your wisdom with each other. It's amazing. And we are actually going to do another episode of this Stronger After Stroke podcast with you. So we'll have part 2 coming, but we'll also have an episode where we talk about the mind-body connection.
Okay.
And so listen up for more tips and tricks on how you can learn to be more aware in your body as well as regulate your body yourself. So we will see you in the next episode.
Thank you, Rosa.